Well, Rich, you about ready to get started?
Good evening, sir. I am ready, able, and willing. Let's get going with this. Treat 99% of your sleep patients with these 4 devices. Welcome, everybody. Thanks for spending part of your Tuesday evening with us.
Us at National Dentex Labs, and we're going to get started. We got a lot to get through. Hello, I'm Dr. Guy Yatros. I'm the one on the left side of your screen. That's my partner there on the other end. And Texas, Dr. Richard Drake, and we've been doing this between us over 30 years, I guess now. Add the two of us together, we've done thousands of devices, and we're going to hopefully impart a little bit of what we've learned along the way to you all. Thank you for NDX Labs. We're sponsoring these programs. We do these programs about once a month, and we've been working with them for a long time, doing a lot of our devices through them, and I always mention that this is one of my favorite devices. I wear a dental device every night myself, and this Clear Dream, I think I had model number 1 they made multiple years ago, and I'm still wearing the first one they ever made because it's made out of injected acrylic. They actually wax it up and make it out of an injected molded process, which makes it a lot stronger than some of the other dorsals. And I'll say this honestly, that it's one of the best values on the market. It's a dorsal design at just under $300. It's really hard to beat, and one of my go-to devices we'll be talking about in a little bit. They also do NTIs. Rich, you still do some of these for your clinching TMD patients, I assume?
Yeah, every now and then, we can't get their mouth open far enough to get an impression for a dental device, so we got to get them relaxed a little bit. So yeah, this certainly has a place. We could talk about that for 2 hours, but we're not going to talk about that tonight. We're going to talk about dental devices.
Yeah, and who we are here at Dental Sleep Solutions. I think we're pretty proud of our mission statement because we do live by it every day, that we're the most trusted, innovative, and customer-focused provider of solutions in dental sleep medicine. Basically, we're here. Our sole purpose is to help dentists succeed at dental sleep medicine. And as any of you that have been doing this for any period of time know, there's not any one piece of dental sleep medicine that's difficult, but when you try to piece it all together, that's where a lot of offices get bogged down and get confused. And we help with everything from education to software to training, both through the internet like this, through our software, and also through live courses. Tonight, if anybody wants to attend one of our courses, we do them all over the country. We're always adding, so you can look at our website. We offer tonight, if you type in course, we'll offer you $50 off a 1-day course or $200 off on our 2-day courses when we have those. So we'll put that up towards the end of the webinar as well. And again, we're here to help with all the aspects of dental sleep. And if you need any help, even whether you're a DS3 member or not, contact us, and we can certainly get you on your way. I think we mentioned that we were going to talk about the practice parameters, and I think I'll talk about the 2006 ones because it's about the time I met Rich a little bit before then, and I was doing 2 or 3 devices a month, and insurance wasn't paying for a lot of them. Physicians were not getting behind these devices. They were still referring most of their patients for UVVV surgery. And in 2006, the American Academy of Sleep Medicine changed their practice parameters to state that dental devices were indicated for mild to moderate apneic patients as a first line of therapy, as well as for CPAP patients, even if they were severe, if they couldn't tolerate it, instead of doing surgery. And that's when I really started putting a lot of emphasis and really started excelling my dental sleep practice. And that's really not that long ago when you think about it, Rich. I mean, it seems like I've known you a long time, but really 10 years is not that long to gone from this being something that wasn't as widely approved as it is now. And now the new parameters came out last year, and I know Rich has read that in detail. What's the difference about them?
Yeah, I think I read all 67 pages 3 times, Guy. I should get a medal for that. But, you talk about, Guy, back in 06, I've heard you say, man, that was the day the earth shook in dental sleep medicine. And you were right in a lot of ways because we didn't have a lot of validity. There wasn't a whole lot of stuff out there that really said what we did worked well. And that was the day that the earth shook, as you said, and things started to change for us. And I think ever since that day, it has gotten a little bit easier for dentists to do this. And obviously, we started Dental Sleep Solutions just to help dentists get over some of these hurdles and these humps. But the new practice parameters, I think in some ways, are a step backwards because there's a lot of political stuff going on here, and it's a little bit of a turf war. But there are some good things that we can take out of that. So they took 11 questions, and then they just said, okay, we're going to look for randomized controlled trials that answer these questions. And they came up with about 500 different studies. So what came out of that was you need a qualified dentist to do this. And they specify a qualified dentist as someone who's had 25 hours of CE specifically related to dental sleep medicine. So I think that's a good start. When you think about this, I think a fair analogy is, when you think about doing ortho, you take a couple of classes, but you've got to have some hands-on stuff, and then you still need more CE. The MD should be prescribing the dental devices, and there's a couple other things in there that you need to do. The MD should do the follow-up sleep study to validate that it's working. So that's what we preach. You get a diagnosis, you make a dental device, and you send them back and get the thing done. So you can certainly use the new practice parameters to your advantage as you go out there and you talk to these dentists as you're doing this.
Yeah, and I believe that basically they want you to be more educated, and I think that's a good thing. That's part of why I think dentists maybe got a little bit of a bad rap about these devices not working because we weren't doing it properly. And courses, webinars like us, courses across the country, there's a lot more resources now to become educated. And if you do this right, you'll fall within those parameters. Today we got a lot to go over, so we've only got an hour, and we typically run fairly on time. So we're going to talk quickly about taking the bite, and then we'll talk about how we decide which device to use where.
Unmuted.
And also we'll talk about which are 4 devices that we use primarily for most of our cases, and what do we do after we deliver the device. So taking the protrusive bite, we call this a 3D bite. We're going to use whatever type of impressions you take. So we're not going to talk a lot about that, except for that you want to get good impressions all the way up to the gingival margins, even up into the vestibules, because some devices have elements of the device, like the dorsal, that goes up into that area. So you want to get an impression up into there. I use a polyvinyl. Rich, you still use digital, right? You've got digital in your new office.
Yeah, we've been taking scans for a while, but either way, this is Dentistry 101. If you don't have a good impression, you can't expect whatever it is you're having NDX make for you to fit. So get a good impression.
Yeah, and then we're going to use, there's different gauges out there. The George, and I think I noticed my slide here saying tap gauge, even though I proofed this. It's actually the Pro gauge is what they changed the name to, and I must have put an old slide in there, so apologize about that. It's the Pro gauge. Is the one by that Airway Management makes, and a George gauge are the 2 most common ones. There's other ones out there you can use, but basically we're trying to find a comfortable forward position to put our patients and select the vertical. And typically for the vertical, you need at least 4 millimeters of clearance in the posterior area, because you need a couple millimeters of acrylic on each arch. So at the thinnest spot, about 4 millimeters will usually suffice. And maybe a little less with some devices. So we use the 5 millimeter white bite port with the George gauge, or the 6 millimeter with the Pro gauge, and that'll usually give you that clearance, but you still want to visually check. And then we're going to look at the range of motion, and I think we have a video here that shows that.
All right, I have a George gauge here now, and we're going to take a protrusive bite and measure the range of motion. Okay, Rob, I want you to gently bite into that. Same type of things with the other bite registration things that we use, where the upper teeth get centered in the upper groove, the lower teeth in the lower groove. Occasionally you have to adjust that a little bit if the teeth are malposed. So Rob, I want you to go ahead and move your lower jaw forward for me now. Very good. So he's going to about 7 there. Now go back the other way as far as you can. To about 3, 2 to 3. So we get in his range of motion with this particular George gauge. Go forward again as far as you can. We're just looking at the difference between those. Very good. Now go back the other way. And we're going to take his bite at a forward and comfortable position. For Rob, we've determined that's about 40%, so go slowly, slowly, slowly forward. So that's going to be about 4 or 5 millimeters. Okay, right there, we'll stop. We'll go ahead and tighten that screw down, and that's when we take the bite.
Yeah, and again, that video is maybe a little hard to see those numbers, but we're going to set it at about 40 to 60%. I like squirting the impression material around the bite fork after we set the bite instead of having them bite down into it, because the biggest mistake you can make is getting the bite off to the one left or right and not being centered for that patient. And also keep in mind that most devices go forward readily, but don't typically go back as readily. So we want to not overdo it and get at a position that's forward, keeps their jaw from falling back. We should get some help there, but if we don't get where we need to go, we can go more forward. Anything you have to add on that, Rich?
Yeah, we could talk for an hour or two about that. Dentists love all these details, right? So the take-home message, just like Guy said, is forward but comfortable. Right.
So, I mean, again, how do these work? And I love this slide because we talk to our patients about why we should be involved in this, who should be looking for this problem. And, this isn't the only problem that it has, but a lot of it has to do with this big muscle of the airway called the tongue. And as it falls back into the airway, we get a narrowing or a blockage caused apnea. And I think we were going to spend most of the night talking about which devices to use where, but the truth of the matter is they all do the same thing. If you look at our slide here, the white is the mandible, the red is the tongue, and the blue is the airway. And as we move the jaw forward on these sedated patients under MRI, look at the difference on the before on the left and on the right. We actually three-dimensionally open up the airway. The lateral expansion of the airway is actually more profound in many ways than anterior-posterior, although we do get both. So, I mean, that's what we're trying to do. We just really try to find which device will work best. And, dentists, Rich, they want exactness. I mean, that's the thing where dental sleep is a little bit different because we don't have an exact, but I can tell you, I think we have a way coming up here that will work about 95% of the time, which is...
Yeah, I'm going to tell on you, Guy. I showed up in Florida one day, and I saw Guy, and he was standing there with his hold on, and he had these devices on the wall, and he's just throwing a dart, trying to tell.
This will work most of the time. I mean, 95% is pretty high success rate, So I mean, and we're kidding, but we're not. But because honestly, most devices would work on most people, and I think the key of what you can get out of what we're going to go through this evening would be if you can make sure you don't pick if you pick the ones that are contraindicated for certain patients. Let's figure those out, and that's what we want to do is basically stay out of trouble. And other than that, most of them will work for most people. And Rich has been saying this. You've got me saying this now that no matter how much we help, what's the saying, Rich?
You still got to use your brain. Yeah, that gave you that thing, and so use it. So we're going to give you some ideas about, and I think I like what you really said there, Guy, about let's just try to stay away from the devices that we probably shouldn't make on a couple of these types of patients, and that'll keep us out of trouble for the most part. But, we designed this device selector, and we put a lot of effort into this, and we use some algorithms that go into this, and you basically, and I think mentally this is a good way to go through this. You just look at the patient. Do they Brux or not? How big is their tongue? Is their bite deep, shallow, class 1, class 2, class 3? Do they even have lower molars? How well can they breathe through their nose? Is their TMJ bothering them? These are the types of things that we put in there, and this is a great start. Those of you who are DS3 members know, and you guys use this thing a lot, and it gives you a great idea about which device to use because we score them that way.
And what I tell the DS3 members is look, just stay away from the ones down the bottom of the list. Stay up to the top third of the list, and you'll probably be okay. So it's a good way to screen. And by the way, anybody who wants to try DS3, you want a free trial this evening, just type in free trial, and someone will contact you tomorrow and set you up, and you can try out this device selector and all the other tools and help we have to help you do dental sleep in your practice. Just type in free trial at any point, and we'll be in touch with you. Again, when you do your exam, we're going to go through each of these with a little more detail. And I tell my patients, we're doing an exam. We got to look at your tissues. We got to document things for our medical chart. But also, we're deciding while we do that exam which device might be best suited for them. So, as Rich said, we're going to have them open and close their mouth, clench your back teeth. Yeah, biting hard. Let's look at those masseter muscles, and are they clenching? Moving your jaw forward, we're going to do the range of motion, and that could affect which device, because some devices have small increments, other ones have bigger ones. And I think one of the biggest ones there is, can you breathe through your nose? And how much money could you bring with you? You know, we're being sarcastic, but some of the devices can cost more than the others. But most of the ones that we're going to go over today are in the same ballpark. So this tongue here, that your patient, Rich? I mean, that's a notable scalloped tongue.
Yeah, you gotta pay attention to these things, and this is where dentists usually excel. So we're trying to give you some tools in your bag that you can look at. So that slide that Guy kind of went through, we're going to kind of go through each one of those now. So yeah, stick your tongue out. Let me see it. And any time you see that scalloping, then you know that tongue is too big for that mouth. It's trying to fit inside those upper teeth. So big tongues usually is why the patient is sitting there and they're talking to you. You got to ask and document about joint problems. I mean, when I started this guy 20 years ago, we didn't make dental devices for people with dental sleep devices for patients who had TMJ problems. And you know what happened to those patients?
They got worse, both their joints and their airway, I would assume.
They died.
Yeah.
So, you know, so don't let this scare you away, but at the same time, use your brain. Ask, listen, palpate the masseter, the temporalis, the sternocleidomastoid. You can even put your glove on, put your finger in there and do the pterygoids and things like that. So just document what's there. I can't tell you how many times, Guy, we put a patient in a device and they go, well, you know, my jaw started clicking. It's never done that before. And I go, oh, that's funny. When we did the exam, you told me every now and then it clicks.
Right. You want to certainly document it. It's rarely that a joint problem is a contraindication, at least in my opinion. And I know there's debate about that, and some insurance companies think it is. But we make a lot of people actually better with TMD problems. And I think the main thing, too, Rich, to note, is it a joint problem or is it a muscle problem? If it's a joint problem, if they do have clicking, popping, crepitation, there's something going on with the joint. You know, if you have CBCT, we talked about last time, that's nice. But even without that, if we can identify it as a joint problem, the difference really is going to be, I'm going to make them a device that hits at least in the back or all the way around. We certainly don't want to make them one that only hits in the front, because that puts a little more pressure as it fulcrums across that pivot point in the front. If it's a muscle problem, we might want to do something that kind of mimics an NTI made by like NDX. You know, the NTI, they're the company that made that famous, and what that does, it decreases the strength at which we can contract our muscles. So it may help the muscles but hurt the joint. So identifying whether it's joint or muscle is going to behoove you. And then, like Rich just said, documenting it, because I can't tell you the number of times people come in and now they're saying their jaw's clicking, and we already noted it at the exam. Maybe that's just because I live here in Florida and all my patients are getting old and forgetful. But you know, regardless, it's really good to have that documented.
It is very good. And just check the range of motion. How far can they move? Open? Can you get 3 fingers in there? What missing teeth? Some of these will be patients of your record, and you can just put in there, you know, see the dental record when you do that. But Mel and Patty, you look at how much of their back of their throats you can see. So as we walk through this thing, you're just kind of trying to figure out where these patients are and what they do. I think a big deal is, you know, one of our biggest problems, Guy, day in and day out as dentists, is getting the device to fit properly, too tight or too loose.
Right.
If you have very short clinical crowns and very straight teeth, that is going to really make a difference on which device you use. So you got to look at this and pay attention. Yeah,
and sometimes we can't get the device to be retentive because of the undercuts and the short teeth. Other times we may not want the device to be retentive. I always joke at my courses saying, how are you going to feel if you do a guy comes in and has 4 5-unit high water gold bridges that G.V. Black himself made? Do you want them struggling and pulling on those with a lot of force every time they take the device in and out? because you're just going to dislodge those bridges. So on occasion, you want it to fit loose. And as we look at devices, if it's going to fit looser because you want it to or because it has to, then maybe we want a device that allows the patient to open so it won't dislodge as likely. So we'll go through that with the devices. We did promise on our on what this course is about. We'd mentioned sleep bruxism. We're not going to spend a ton of time on it, but these patients do brux at night, and come to one of our courses if you want to learn a little bit more about bruxism. But I was taught that bruxism was really because the teeth don't align right. We grind our teeth at night because they're not hitting together right. And far and away, that's becoming, at least in my opinion, and the research of the sleep specialists, a little bit more disproven. If you listen to the sleep gurus, and which this is the Principles and Practice of Sleep Medicine, so there's not a bigger, more well-respected sleep book written that we reference these days, that OSA is 2 to 3 times higher in people who also grind their teeth, and they feel that the grinding of the teeth has to do with not sleeping well or these micro-arousals that happen at night. I know you did quite a bit of research on bruxism as well, and Rich, you can share some of that, and also maybe, how do we identify these patients, because that could certainly affect which device we're going to choose.
Yeah, just look. I mean, this guy, he may not be bruxing his teeth now, but at some point in the past he obviously has. So look, palpate. I think one of the best ways to evaluate present day awake, and you can talk about awake bruxism and sleep bruxism, and then how that relates to TMD. So again, those are all 1 or 2 hour topics, each and of themselves. But right now, we're just trying to figure out which one of these 4 devices we want to make this patient. So we have to go through this process a little bit faster in our head and more efficiently. So palpate the masseter muscles. If they can bite their teeth together for more than several seconds without pain, then they may be doing some clenching, but it's not over the top, so to speak. So right. Evaluate, ask, look, palpate, listen. Some sleep labs and sleep devices even have EMG attachments on the masseter muscles, so you can look at that as well too. And that may be a good end for you as you talk to the sleep docs in your community. Right. But like you said, you want to look at awake or sleep, and as you look at this, what do you want to say, Guy?
Yeah, I was going to say, we can't tell by looking at this patient, do they currently brux their teeth at night or even during the day? All we can do is say, some point along the way, it looks like they've ground their teeth, and doing a little detective work and determining when this happens and when it doesn't will help you decide on which device. And, if we see this lady, hopefully we'll notice that her Arnold Schwarzenegger masseters there develop from exercising those muscles. It's just like any other muscle. We do bicep curls, our biceps get bigger. We do masseter curls, and our masseter gets bigger. So let's try to pay attention to that, because certainly we mentioned at the beginning of this, keeping you out of trouble. Picking the right device for this patient might behoove us and save us from having to do a remake down the road. Is this your dog, Rich?
I love that. I trained that dog to do that. But you got to look, is it deep or shallow? Because sometimes, remember what Guy said back in the beginning about taking a bite. He said you got to have at least 4 millimeters of distance between the posterior teeth, not between. You got to have at least that in the anterior teeth too. So that depends on the curvature speed, if your bite's, class 1 or class 2. But again, this is one of those things that we want you to look at and evaluate.
Yeah, so if you see a patient like this that has a 10 millimeter vertical overlap, just to get their teeth to edge, we're opening them 10 millimeters. I think it's the point there. And then whatever device we add, we'll add more vertical to that. So we might want to pick a device that has less thickness, less stuff in the back, so that we can make it thinner in some cases. Can you breathe through your nose? And that's a really important thing. We talk about allergies. Here in Florida, allergies are pretty prominent. We talk to patients a lot of times about using the over-the-counter steroids such as Nasacort. These days I get a lot of my patients doing that. But if they can't breathe through their nose, or they have occasional or frequent nose problems, and it could certainly affect which device we're going to choose, because I know this is me personally. I have both allergies, and my nose have been broken on multiple occasions. And certain devices aren't as comfortable for me because I can't breathe through my mouth, and we just need to analyze that. I use a fancy trick. I think you told me, Rich. We talked to them, and then I have them breathe through the nose, and I put my finger on the side of their nose and close up one of the nasal valves there and have them breathe, and then do it on the other side and listen to if the air is going through and talk to them about that. So it's a pretty easy technique, just having them breathe and close off one side and then close off the other, and let's determine if on a daily basis their nose is more or less open or closed.
Yeah, that's a good point. Maybe we could patent that procedure you've got going.
It's you can learn it. It's a lot of practice that went into it, but you can figure that out.
You put your finger on the outside of their nose, not the inside. So
yes. This is my typical patient here in Florida, right?
Yeah, I mean that's a bigger deal for you guys than it is me, because you probably treat more older patients. So if they're gonna have to change a rubber band or something like that, so you just got to evaluate it.
Yeah, absolutely. I mean, and we have patients who've had strokes, and you got to think: can they take this device in and out? Can they, if the rubber band comes off, can they put it back on? A lot of times we have the patient adjust their own device. Now we don't mind adjusting it, so that's probably not the only thing we would look at. But they've got to take the care of this device themselves. And so we're going to make sure that we think about that when we select the device. And then cost is a factor. Again, most of them are in the same ballpark. And I personally try to make the decision based on what's best for the patient and not the cost, and getting the patient involved in that decision based on cost will run you down the wrong road every time. So again, there's our device selector. The way that works, basically you slide the bars back and forth based on how big their tongue is or how big a bruxer they are, and it resorts the devices in an order. So before we get into the 4 devices, we're going to talk about the materials. The devices are made out of acrylic, but what's inside the acrylic, the part that touches the teeth, can vary based on the specific device you're doing on that particular case. So basically, we'll break these down into 3 categories. Different labs call these different things, but we'll just try to give you 3 broad categories. And acrylic's the easiest one, so I'll take that and let Rich talk about the next one, because acrylic's easy. You as dentists know about acrylic. You're familiar with acrylic. It's nice because you probably have quick cure acrylic in your office, and if you need to make an adjustment, if it's too loose or something, you can add some acrylic around it, just like you would with your bite guards. If they have a crown, you can mix them up and add around it if you refit it. You can get the acrylic with or without these ball clasps, like on the bottom picture here. The ball clasps are nice because you can tighten or loosen the device, but they're also bad because they can actually get bent over or get loose, and you may have to constantly fiddle with them. And also, if you're going to do the ball clasp, make sure the lab wraps this distal of the last molar. Because if you have a ball clasp between a first and second molar and no third molar, and you have that back open, you now have an orthodontic device because you're going to separate those teeth there. So it can definitely cause some separation of teeth as well. I typically prefer the non-ball clasp on these. One last thing about the acrylic is it can be maybe last longer, or you can make it thicker because it's acrylic through and through. Some of the other ones basically are made out of 2 materials, so you may have to have more thickness, or the acrylic may be thinner. Anything on the acrylic before I let you talk about the Flex, Rich?
No, that's very good.
All right. Flex liners. You want to?
The other option is, and this is a little bit more comfortable. It's that some people call it a dual laminate, and some people call it a Flex, and it's that little bit softer, spongier layer on the inside that goes against your teeth. So it is more comfortable to wear. It has a little bit more give to it, so your fit doesn't have to be quite as exact as it does with an all acrylic device. It does flex underneath the undercuts a little bit, and that does allow the device to stay in a little bit better when you have straight teeth. But like I said, it does add to the thickness of the device itself, and it can delaminate from the underside.
And it's a little hard to adjust, too. So if you got,
it's harder to adjust?
Because you get that burr in there and it gums up. You can try to use a blade. It just, it gums up. Yeah, it really is. But again, it's more comfortable. So if I'm looking for comfort, I'm looking to get around undercuts, we use the flex type materials. And then, Rich, you have been preaching the values of Thermacryl. As a matter of fact, you can go to our Dental Sleep Medicine Insider, the very first edition. Rich did a funny and informative video on Thermacryl. You've been preaching about Thermacryl forever, and I finally have eaten the Thermacryl or taken the Thermacryl drug. I like it too. I'll let you explain about it since you've been using it since I was born, probably, right?
Yeah, it's just a thermoplastic. You heat it up and it gets kind of soft like Play-Doh. And then you mold it, and as it cools, you tease it in and out a couple of times, and then you have to trim it a little bit. So if you got somebody with you've done perio surgery on 4 times and you got all these undercuts, don't take a phone call while you're fitting them because they can get stuck and you have to be careful. So I think dentists don't like this guy because it just has a bigger learning curve. But once you get over the learning curve, this always fits. It always fits. You can add acrylic, you can take it out. Thermacryl, you can take it out, but you just heat it up. You put it in the mouth. You have them close down on it real hard, or you push real hard on it, and then you tease it in and out. You just cut off the little bit of undercuts and things like that. So this is a great device, for example, if you got a patient that has severe sleep apnea, they can't wear CPAP, but they need a bridge, they need an implant, they need a couple of crowns done. Well, don't put off treating their sleep apnea until they get that done. Just use Thermacryl in your dental device.
And I think what's made it better for me, the first time I did this years ago, the lab just delivered it with kind of like a hot dog of that material in there. It wasn't fitted to the teeth at all, and I had to do all the fitting chairside. NDX does a great job. They actually fit this to the models. So most of the time I run it through about 3 seconds, 5 seconds of hot water, and it goes right in. By the way, we have videos on how to do that. Again, if anybody wants a free trial, just type in free trial, and you can have access to something we call Snoozle, and it shows you exactly how to fit that. We give you a couple-week free trial, and you can learn this yourself. And again, if you want to go to any of those courses, just type in course. We'll put those at the end, and you get the discount on the courses as well. All right, we're going to talk about some devices now that we've talked about the materials and how we select them. And here's the 4 devices. And actually, we're sneaking in a 5th, which is kind of a variation of one of them as well, that we're just starting to do more of. And the dorsal design, I think far and away, if I had to just select one device, this might be the one. It's the one I wear myself most nights. It's named after this dorsal fin that the devices have. And then the NDX one is the Clear Dream. It's their specific brand of dorsal. And again, I think it's by far the best value out there on the market because it's a very reasonably priced on the lower end of most of them, as a matter of fact, maybe less than any of them as far as I know. And it's stronger because it's made of that injected acrylic. So the features on this, what I like about it, a couple things. Primarily, one is the increments are very narrow. Let me back it up for just a second. The way you adjust this is you put a key in here, and you can see the arrow, and you move it in the direction of the arrow. And one turn will move this piece of acrylic forward 1/10. So very, very minor adjustments of a millimeter. So 10 increments equals a millimeter, and you can go roughly 6 millimeters with most labs. And depending on the lab, you can get flex and hard of acrylic. I like the the Clear Dream with just the hard acrylic in it is what I prefer. The other features on this, it does allow your mouth to open, and to me, that's very comfortable. And for me, I can't breathe through my nose. It makes it just much easier for me to adapt. And you can make this. You can see the one on the screen here has an anterior opening. You can make it that way. You can make it hit just in the front with like a NTI type stop. You can have it hit all the way around. You just need to tell the lab. But for somebody like myself, having that opening is great, especially if they have a big tongue. You may want to open the bite a little bit and do it. But then on the opposite may be true. If you have someone who can barely open their mouth, they have a 25 millimeter vertical opening. You can make this at a very minimal vertical, and they can place the upper and then the lower in place. I'm going to go ahead and put the cons up there on the screen for you. And last thing I'm going to mention, I know Rich probably has something to add on this, is that any of the devices, and there's 2 of them that we're going to show you that allow the mouth to open. That's wonderful. It allows the mouth to open. The patient can swallow. They can breathe better. But at the same time, it does add an element that we don't control. Now the vertical can be changed at any given moment. And sometimes that's a bad thing. So anytime you have the ability to open with the device, we recommend having a way to place orthodontic elastics so that you can keep the mouth more or less closed when the patient's relaxed. So this one, the neat thing is the acrylic's so strong, they don't have to put ball clasp or anything to add the elastics. They just make a couple of slots in it, little groove slots, and you can make those yourself, or they'll do them at the lab, and so there's nothing poking the patient, so that you can add orthodontic elastics, because sometimes that'll make all the difference in the world with this particular device. What else do you have to add on the pros and cons, and then Rich, we're going to talk about where we use it and where we don't.
You covered that pretty well. The only thing I would say that you didn't touch on was the durability on the con side of that if the jack screw is advanced too far, and that's simply a matter of torque. So that's just a standard jack screw that's used in things like palatal expanders and things like that. And as that thing moves out to the end of its range of motion, it just has a longer torque arm, and it can break off. So that goes back to taking a forward but conservative bite. And if you get that thing out there real far and you still don't have the patient where you want it, just take a new bite that's a little more forward, send it back to NDX, and they'll reset that thing for you without it breaking. That's a way you can be proactive about intervening.
And if you look, we're talking about right in this area. And notice I have cost down here at the bottom with a question mark, because a lot of you are familiar with some of the other brands of dorsals, which may be in the neighborhood of $600. So again, NDX is the cost is one of the most reasonable of any device out there as far as that goes. So and I think what it boils down to is, who do we do this on? And first of all, this is not a Medicare approved device, so for those of you Medicare providers, we can't use it on them. But for my non-Medicare patients, I'm looking at the patients with a large tongue. Myself, I can't breathe through my nose. That's one of the reasons I like. I'm a mouth breather. Minimal teeth. The reason we talked about those undercuts and so forth, this device allows the patient to open. And I'm going to back it up for just a second. If you can think about this, there's not a lot of force pulling down or up on the lower and down on the upper. You can make this with fitting fairly loosely, and it will still work. So if some teeth are missing and you don't have good retention, it's not going to pop it loose from each arch. It's good for deep bites because you can make it very thin. So again, deep bite, you have to open someone up 8, 9, 10 millimeters just to get to the size of the edge apart. And I think it's one of the most comfortable devices out there. Rich went over the Bruxer. Someone who's a real heavy Bruxer, even though this device is made very strongly, that very back piece can break even with the Clear Dream, although I think it's one of the more stable ones that they are. And the limited vestibular space, I think, is the other one. I always take my finger and put it back there right around number 2 or number 15. Have the patient open just a little bit. And if you've ever had that person where it's really hard to cut a buccal crown prep on number 2 or 15, and there's just no room to get your burr around there, well, be aware of that, because that's where that attachment's going to be. And that jack screw, as Rich called it, and sometimes that can impinge on patients if it's really tight, where the coronoid process comes in there. If it's marginally tight, you're fine, but if it's really tight, you may consider a different device. Anything else on you can tell I like the Clear Dream because it's one of the ones that I use real regularly here. Anything else, Rich, on the more or less?
No, you covered that one. Excellent.
All right, Medicare. Rich and I are both Medicare providers, and you don't need a dartboard for Medicare. All we need is a coin, because there's 2 devices that we do, and it's the Herbst and the Tap 3 Elite, and I guess actually 3, because there's a different version of the Tap that we'll talk about. And Rich, I'll let you know, you converted me to taps too, because I tried a tap on myself years ago, and I didn't like it as much as the dorsal, again because of my nasal obstructions and my inability to breathe through my nose, and it just made me feel like I have a lot of saliva too, and I couldn't swallow as well. But daggone, these things work, and I use them every day. And I know you've been a big fan of taps for many years, so you want to talk about this Tap 3 Elite?
Yeah, I go all the way back to the Tap 1, and then we had the Tap 2, and then we had the Tap 3, and then we had the Tap T and the Tap 3 Elite, and then now we're on the Dream Tap. So we keep changing that. Keith Thornton keeps changing that, and NDX is great at keeping up with all these types of things, but there seems to be some difference in where you pull or push from as far as the effectiveness of a device. Now, some people would argue that, and that's okay. But again, we want you to have more tools in your tool bag so that you're going to evaluate these patients on these things, just like we've been talking about. Now we've got a screw. We've got a couple of different hooks, and that hook just fits in between those patients, those bars there. I'm sorry, not the patient, the bars. And that's what makes it Medicare approved, because now it can't come apart. So the screw on that has about 6 millimeters of room. They do come with a couple of different bars, so that now you have approximately 12 millimeters range of motion without having to actually send it back to NDX and have them cut that plate off and move it or something like that. And you can get it with the what Airway Management calls a triple laminate, which is that soft flex part inside, or you can get it with the Thermacryl.
Which I almost always get the Thermacryl, because this one you want it to fit fairly tight or that'll pop out. And the only thing I'll mention, you said it comes in different bars. To clarify that, there's 3 different hooks. This is the long hook, I think, and then there's a medium, and then there's a really short hook. So it gives you a lot of adjustability near 15 millimeters if you use it in its entirety, just to clarify that. And when do you use this one, and when don't you, Rich?
Yeah, the things we like about it is you can move side to side a little bit more, and with the various hooks, they're always changing these hooks and all that kind of stuff. You do have a lot of anterior to posterior range. Absolutely the most researched. Thornton has been so involved in all of the research that's out there. The things last as well, and we don't have time now to go into hybrid therapy or combination therapy, but you can combine this device in a very easy way with PAP, either through a PAP custom mask or through their chairside system, and it enables you to treat a wider range of patients. Some of the things I don't like about it, Guy, you mentioned earlier the dog picture and the real deep bite. So you got to remember, if somebody's got a class 2 and a deep bite, you've got to open them 6, 7, 8, 9, 10 millimeters just to get their teeth end to end. And the TAP 3 Elite and it requires about 8 to 10 millimeters of vertical in the anterior area as well. So that patient is going to be very open. And that's not always a bad thing, because we haven't talked about vertical and how that plays into treating patients. But the more vertical you add, the more uncomfortable it is, as a general rule.
And it can have negative effectiveness at some point. At some point, it can be positive effectiveness as well.
Yeah, so I use this more on severe disease. Somebody's failed CPAP and they got an AHI of 100. I like TAPs, but when would I might use it less? Might be that person like Guy. He's a mouth breather. He doesn't want to breathe through his nose. So this goes back to our evaluation earlier, where you're doing that type of stuff and you're looking at it. So we use a little less on deep bites. Big tongues can't breathe through their nose as well. We use it more on severe disease, people who can breathe through their nose. And you can make this, I've made this guy with people as few as 5 or 6 teeth on each arch.
Right.
And we certainly like the big cheeks, because if somebody can breathe through their nose, one of their biggest complaints in using the TAP a lot of times is that I can't get lip seal. So my mouth gets dry. So that's why I put the big cheeks in there, because those people, when they take your cheek and wrap it around their ear while you're working on their teeth, I like those. But the TAP is a great device, and it's one of those that you've got to have in your tool bag.
Absolutely. And I'll just finish with saying that the 2 things for me, the bruxers, if they don't have a joint problem, they just have some muscle bruxing. It's just like having an NTI built into your device, and I really like that. And the severe disease, I just want to emphasize, for whatever reason, it just seems to work well. If I had to say one works better than the other, I know I'm going to do all I can. It just seems to lower the AHI. And furthermore, you can actually adjust this in the sleep lab a lot easier if you titrate your devices in the sleep lab, because you don't have to take it out. You put a little key in here to turn this, to move that hook, and the patient can do it, or the lab technologist can do it, but the device doesn't have to be removed if you're actually titrating it in the sleep lab, which we don't do all the time, but we'll talk about that in a few moments about when we do. The Dream Tap's pretty new. I just made one of these for myself, just tried it the other night, and actually I found it to be more comfortable than the than the tap. I haven't done as many as you, so Rich, what are your impressions of the Dream Tap, which is kind of new off the presses here?
Yeah, we probably made about 30 of them at my office here now, Guy, and it really threw us for a loop because the plate's on the bottom instead of the top. So
right.
Everything's upside down and backwards from what you got used to, with the older taps. But a lot of the cons that we had in there with increasing on the tongue space and a lot of that stuff they've gotten rid of with this particular design. So again, the plate goes from the top to the bottom. They have two different versions. They have the Medicare version and the other one. So it's just how easy it is to get that hook onto that round bar that's up there. So, but it does give you a little bit more room for the tongue. But all of the other things with the tap basically still apply. But I would encourage people to use the Dream Tap. I think it's a better device overall because it solves some of the tongue space issues.
Right, and it's a little less vertical, I think, too. So as you said, so I'm excited to start using it. NDX makes 3 of the 4 devices that we're talking about tonight. They do not make this one, the Herbst, which is the other Medicare-approved device. And basically, I use the Herbst in areas where the tap's contraindicated. And the way it works is you have a little instrument you put here on the side, and you can see this little plus. You turn towards the plus, it moves that piston to the posterior, which moves the jaw anterior. And they're roughly 0.8 millimeter increments if you do a quarter turn, or a fourth millimeter if you do a full turn. And we can roughly move this piston about 7 millimeters. There's one called the Advance that's a little bit different. And there's also telescoping arms where you have male and female. And you can get these in a variety of materials. And the pros and cons on this one are pretty similar to the dorsal. So if I have a patient like me who can't breathe through their nose, and maybe the AHI is a little lower, and the patient really wants to be able to open their mouth, they have the minimal teeth, kind of some of the same pros and cons as the indications as the dorsal, we may consider this one. One of the things is I think it holds up a little better than the dorsal. It's got metal there, and you don't have quite as much likelihood of breakage, although again with the Clear Dream we get a lot less. You have a little more lateral movement than you do with the dorsal, but not as much as you do with the tap. And it does allow that opening. By all means, you can see on this one here, it's got little hooks here, ball clasp. These ball clasps are to hold the teeth in. The anterior ones I'm talking about here, those are meant to put elastics on. And this device almost encourages a mouth opening. So I almost always have the patients wear the elastics with this device. And the cons are it's kind of ugly. Cheek irritation is something we do encounter, not as much as you might think, but it does happen. And it's a little harder for the patient to adjust, but we do now. Most labs now will put red or blue dots in the positive direction into the acrylic so that you can actually see which direction that they go in. Again, this is a Medicare device, and so if they have a big tongue and can't breathe through their nose, the tap's contraindicated. So I'm going to more likely do the Herbst if I want to open the mouth. And if when Rich said for tap minimal teeth, it really depends on where the teeth are too. If you have 6 through 11 or 4 through 12, then a tap's a fantastic device to do, probably the best one of all the other ones, as long as those teeth are periodontally stable. But now if you're, have some teeth that are maybe missing sporadically or just on one side or something, and this thing needs to fit loosely for whatever reason, then we're going to do the Herbst on this particular case. I don't think, from the Bruxism, I like the anterior stop on the tap. Now we can do that on this. We can tell the lab to make it any way we want, but I still prefer the tap for the more heavy Bruxers. And it's a little clunky getting this thing in and out for some patients, and a lot of people just don't like the way this thing looks. It looks kind of a lot of metal. It scares patients probably more than it should. Any other negatives or positives on that, Rich?
No, you covered that well. It's again, what one of the take-home messages here is we like the tap, but when the tongue's big and you can't breathe through your mouth, through your nose as well, we tend to go to the other devices. So, and the flimsiest, cheapest looking one of all of them is the EMA. You just look at this thing. I had a guy the other day goes, you want how much money for that thing? And I thought, yeah, well, it saves your life. I mean, what's that worth? I mean, we'll talk about that another day. But, there's a button that goes on the upper canine and the lower first molar. Now, you can tell the lab you want that changed a little bit, and sometimes you have to do that if they're missing premolars, for example. It's a post-ortho patient and their premolars taken out, or they don't have a particular molar. But in general, on a class 1 patient, that's about 26 millimeters. So if we put a 22 millimeter band on there, then we're going to adjust that guy about 3-4 millimeters. So, but we like this thing. You just the lab is going to vacuum form this. The NDX will make this. Their standard, I believe, is 2.0 or 2.5 millimeter bioacryl. So sometimes you can get it a little thinner or a little thicker if you have to. But in general, the bands the buttons are going to be placed on the canine, on the upper and the lower molar, on the lower, and then you're going to run through a range of bands as we do that. So the bands come from 12 to 25 millimeters, and they come in different rigidities. There's a soft, a medium, a firm, and an extra firm. But this thing, we love this thing. It's just simple, but it's very aesthetic. It's a little bit easier to get lip seal with it. You can make it a little bit thinner in that particular instance. The lab fee on these is, do we know what NDX charges, Guy? It's less than all of the other ones. I'm not exactly sure what it is.
It's in the low 200 range, I think. So
yeah,
it's 100 or more less than some of them. So it is less expensive for sure. But again, we don't typically make the decision based on that, but sometimes we have to.
Yeah, certainly if we're doing it for free. I mean, have you ever done any free dentistry, Guy?
I've done a ton of it. I mean, we try to help people out when we have to. And I had one recently that was an acrylic allergy that this worked quite well on because we tested them and they weren't allergic to this, and the lady did far better.
There you go. So no metal or acrylic. That's one of the pros on this thing. If you have somebody who has an allergy to one of the screws or some of the metal that's in there. So I think on the con side, we talked about patient dexterity. It's a little bit harder to get your fingers around this thing and get those bands on. Certainly as the bands get shorter, it makes it a little bit harder to do that. And we put in there, too, durability. And there's a caveat there, of course, and that is if they're real severe bruxers, they are going to tear these things up. So, right. And I think we have the contraindications here in a second, but those things, you do have a little bit of range of motion in those, and they are a little bit more comfortable. So if you use a real soft band, you have a little more range of motion than if you use a stiff band. So we always start with softer bands, and then we titrate the patient forward, and we get them eventually into a stiffer band because the stiffer bands will last more.
Typically the blue is what we end up with, I think, most of the time. Just the blues are the next to the most stiffest. The clears are a little too stiff to deal with for some patients. Occasionally we use them, but mostly the blue bands.
So would you say, Guy, this is a little bit the same as the dorsal, isn't it? I mean, we use these on people who, same type of thing where the tap is contraindicated. Big tons can't breathe through their nose as well. We like these. I like these on not so crooked teeth. We talk about the snaggle tooth, and you look at the height of contour on all those teeth, and people whose teeth are really crooked, what happens with this device is it becomes a very short top to bottom, and therefore it's not quite as strong. So because you can't engage all of those undercuts, either that or you've got to have the lab block them out. But right. We tend to use it more on where we need less space, and we put aesthetics in here. I mean, wouldn't you say you're surprised, Guy, at how many times that comes up? People say, well, my spouse really doesn't even know I wear this, or right. I don't want them to know. So. And
when that's an issue, this is your go-to device. It looks like a couple of Invisalign trays, so people don't object to it. So, again, we can't put every situation out there. You've got to use your brains, as Rich has taught me to say repeatedly, but we're trying to keep you out of trouble. And 95% of the time you could just pick one of these out of a hat and it would work. But we encourage you to try each of them, wear them yourself, make them on your team members, and become comfortable, because you probably will develop your own bias a little bit. You've gathered I might like dorsals a little bit more. I like the Clear Dream. Rich still probably does a few more taps than I do, but I've drank the tap juice and the others as well. So after you start doing these, you'll find what you like better, and just don't be afraid to do it. This isn't rocket surgery, as we put in some of our other slides. Now we're going to finish up with kind of what we do after we deliver the device, and we've gone through a lot of things about how we get the jaw to go back through a lot of different devices, and far and away most of our patients these days, we make them what we call an AM aligner. The AM aligner, basically you heat it up, you mold it. There's a process where you can do that around the full arch, or you can do it just in the front teeth area, which I prefer, and you can get these from your labs, and we deliver one of these with every case. And if we get the jaw to go back and they squeeze and they put pressure on their back teeth, and they take this out in the morning after about 2, 3, 5 minutes, and then the patient can say, yeah, my teeth feel normal, then they're finished. And if we'll do this, Rich, we have found many more patients that have, I think, far fewer bite changes. Would you not agree?
I agree 100%. So side effects are a part of everything. I did have a physician laugh at me the other day, Guy. I was doing a talk for a group of physicians, and he started laughing when I started talking about, the bite can change. And I said, what's so funny? He said, man, our side effects kill our patients.
Yeah, that's right.
I think that's one of the things that we just got to get over. But again, we want you to be better doctors. We want you to have more tools in your bag. That's why Dental Sleep Solutions exists, to help dentists be better practitioners at this kind of thing. So what are your 3 goals?
Well, we have 3 goals, and we're going to try to get finished. I see a lot of questions. We've been trying to answer them along the way. Keep them going. We'll continue to answer them after. We'll try to be finished here on time so we can field any additional questions. And also mention that we have videos on how to make that AM aligner. Again, if you want to do a free trial, just type in free trial. You can access those videos for several weeks, and you can see how to make the AM aligners and how to utilize those. There's really 3 goals or steps of treatment, and basically I want my patients to wear the device comfortably, whether they're snoring still or not, or they still have symptoms. Once they feel like I've acclimated to it, we want to look for subjective improvements, whatever their chief complaints are, and then we're going to do a follow-up sleep test. So it looks something like this. We have them back. I usually see the patients about 3 weeks after the delivery, as long as they're comfortably wearing it. You might see them sooner. I know some people do, but the 3-week check has worked out real well, and I think Rich is doing that these days because it gives them time to acclimate to the device so that we're not making little adjustments on the device when maybe it's not necessary. We're going to go through a list of subjective things, whether it's snoring, how many times you wake up a night, and if they're happy with them, we're going to move on to a sleep test. If they're not, we're going to go through a process where the patient will do maybe a quarter or half millimeter increments every 5 to 7 days over a period of 2 to 4 weeks, and then we'll check them again, either by phone and just see how they're doing, or have them come in. Ultimately, we want to get it till we're all happy with the sleep test and move on to the treatment complete. If for some reason the sleep test doesn't show us what we want, occasionally we have to go back and do further titration. But with the system I'm going to show you right now, we don't have to do that near as much. And when we're finished, we're going to see our patients about every 12 months. But initially, we'll see them 6 months after the final evaluation, just to make sure they're doing well and that they haven't had any bite changes and that they've titrated the device to the proper end result. DS3 helps us really evaluate these subjective findings. So when the patient first comes in, we do the Epworth and the Thornton, and a lot of things we went through in some of the other webinars, snoring sounds, and then they're going to come in and we're going to ask them those questions again, and very quickly at a glance we can see this patient's improved. They're snoring from 9 to 3, their Epworth 19 to 8, the times of waking 4 to 1, and this patient's probably finished with subjective titration, which is the second step. If it wasn't this nice, we would move them on to adjusting the device and to do follow-up checks and add additional columns here for the patient. Once they're finished with their symptoms and they feel better, that's when we want to test them. But we certainly want to make sure they're wearing the device comfortably every night first. Have you ever made that mistake, Rich?
I've made every mistake out there, Guy, at least once.
Yeah, so, you don't want to test them if they're not comfortable, because they may become uncomfortable, and now we got to retest them again. And there are really 2 ways of testing them, But the overall goal of the test is that we reduce their apnea. This is the DSM's guidelines of success. We want to get the AHI cut in half and less than 10. But that's not always the only success. We get someone whose AHI was 70 and we get them down to 15, and that's kind of the expectation we set at the consultation. I'm perfectly fine. I'm not only fine, I'm thrilled with that result. I also look at the SpO2 readings. What is the pulse oximeter saying? And if we can get that to where we're not going below 90 at all, or certainly if we can keep it less than 1% of the night below 90, I feel pretty good about that. So understand this is, maybe a guideline for success, but medicine is not black and white like dentistry. If we're going to do testing, there's two ways of doing it. I'm going to try to kind of get through this because we're going to be finished here shortly on time and then open for questions. Is we can do testing with, you can do one night, a home sleep test. It's not what you want. You could advance the device to a test a few weeks later. That's what we used to do. But now what we do, and I'll put it up here, is let's say the patient's baseline, they were at a 29.5 here, their AHI, and we've adjusted the device a little bit, and now their snoring's better. Well, we let them wear it right where they were the first night, and then we have them advance it a millimeter or two the next night and wear the sleep testing equipment. And if it's a 3-night test, they'll wear it at their house a third night, even more forward. And somewhere between the most they can go and where they currently are, we'll have them set it. And then, my gosh, look at this. We have all the information we need to make a decision. We have their baseline. We have where they were comfortably wearing the device based on their symptoms. And now we have 2 more forward positions. And we can quickly see that, well, maybe this last one is where they want to go, and that's 5 millimeters, which they were 4 where they were comfortable. And we'll tell them, key thing here is they need to back it up after that last night back to where they were comfortable, and then they slowly advance it till they get out to this 5 millimeter mark here. And that may take anywhere from a couple of weeks to a couple of months, but then we know where they're going. If you only have a 2-night test, well, we're just going to pick a more forward position for the second night, and then we have a whole lot better information there on how to do it. Used to, we would do 1 night at a time. And then, Rich, do you still do this some at the sleep lab, if in particular if we're doing a tap, to send them there?
Yeah, you can, but I love the way you presented that, Guy. That's pretty slick, man, the way you can see that in that ES3 look there, because it makes it a little bit easier to figure out where you want to be. I think the bottom line is, if you told me, hey, Rich, you got to go back and get a sleep study to evaluate if this is working or not, I think you need to put some sense of urgency in that, because I tell my patients, Guy, that's what helps me sleep better. Now, you may know it's working and you may feel great about it, but I sleep better when I get objective data that shows me that that's happening. So, but my next question would be, well, which does my insurance company pay for? So they may not only pay for a home sleep test, so you may have to do that. So, but you have options. You can send them to the sleep lab, and then you do it a little bit differently, because we would have the patient, the tech, go with very specific instructions, and when, if the AHI is not below 10 or RDI not below 15 or cut in half, then you wake the patient, have them adjust the device for half turns or whatever it is. You want a couple of 2, 3, 4 different sections of that sleep test while they're in the lab at a couple of different positions, just because we're trying to figure out the sweet spot. And we got
Absolutely.
2 ways to do it.
Yeah, so we prefer the home test a lot, but sometimes our physicians want the in-lab test. And again, if you want a free trial, we have in Snoozle exactly how you do that, and the orders that you send to the sleep lab. And we prefer a tap if they're going to do it in the sleep lab, where they come in every 45 minutes and titrate it till we get to the level that we want. So I know that's a lot of information. We are continuing with this webinar series through NDX, and basically dental sleep is really simple. There's just small, simple steps, and if you have a system like DS3, honestly, you can get through this in under 45 minutes of dentist time. I know I spend 30 minutes or less per patient and deliver quality care to my patients, because we have great systems in place. We have our staff trained, and that's what we do at DS3. So, again, we're adding 15 minutes for what you all can do this in, and you can add a life-saving, life-altering procedure to your practice that will make you want to get up and go practice every day. To be successful in dental sleep medicine, we keep touting all you need to do is have these 4 pillars in place. That's what is the foundation for having dental sleep in your practice. And you need a system and team members who are educated in screening, testing, treating, and billing. Dental Sleep Solutions, DS3, we can help all those. We have systems and partners that can help you with all of that. If you're interested in doing a free trial or becoming a member, here's how you can get a hold of us, or just type in free trial, and we can help you with everything from insurance billing questions to online education to systems to some of the videos that we alluded to here during this time. And here's some of the courses again. Again, we ran about 2 minutes over. It's a little after 9 here. I know we're still typing in some questions, and we'll stay on to answer those questions. I'll leave this up for just a moment. I appreciate anything else, Rich, to add. I know as we're answering these questions, typing them in.
No, very good. Thank you so much for putting that PowerPoint together, Guy. You did a good job with that. And, we are here to help you guys succeed at this. And I know that NDX is too, but you guys know a lot more about this now than you did an hour ago. So we appreciate you spending some of your evening with us. And please reach out to us if there's anything we can do to help you.
Yeah, that's, again, I should probably enter for a mission statement sometime, but we are the most trusted, innovative, and customer-focused provider of solutions in dental sleep medicine is our mission statement. And basically, we want to help you succeed at dental sleep. That's what, when your patients are happy with your dentistry and they come in and they give you a hug and they say, thank you for my beautiful teeth, we feel the same way about helping dentists and dental offices when they thank us and say, we appreciate your helping, and boy, you've changed our practice, and that's what we get pleasure out of, and that's what we're all about. So any questions that you want, let us know. You want a free trial, want to come to one of our courses, just want to know what we're more about, then give us a contact via email or phone, and we're here to help. And keep these questions coming in. I think we'll just try to type out the answers here as we're finishing up. And thanks again. Everybody have a good night.
Have a good night, guys. Thank you.